Now, the most common use that we've seen in colorectal surgery fluorescence imaging has been that of perfusion assessment, particularly in left-sided resections. So if we're talking about an anterior resection, we can now look at the colon both from the proximal transection as well as the anastomosis, the colorectal anastomosis, with a little bit more objectivity. And that means injecting a dye such as indocyanine green and looking at whether or not the bowel itself is perfused. There's been good observational data from the Pillar 2 trial from the States, as well as the European trials that have been run by Fred Rees and his colleagues. We still await randomised control evidence, and we'll hopefully get that in the next few years through David Jane's trial, the INTACT trial. But certainly this gives us food for thought about whether or not we can look at the perfusion of the bowel, particularly in anterior sections, and whether or not there's any utility of using fluorescence in these cases. We do know that if you do have a leak as a patient that's had an anterior section, that often those oncological outcomes are not quite as good as they should be. And beyond the obvious problems of having an anastomotic leak, there is an oncological consequence too. One of the other more novel ways of looking at rectal cancer and fluorescence is the use of lymphatic mapping and the use of identifying nodal disease. Now, of course, with a totomesorectal excision, where the operation is standardized, perhaps understanding the lymphatic map is not so necessary. But of course, if we're doing a more bespoke operation or trying to identify nodes in the pelvic sidewall, then being able to target this with greater precision through fluorescence may be of use. We should see more accurate fluorophores and more specific fluorophores with markers such as CEA attached to them as we progress through over the next few years and as the research comes through. One of the other ways that we can use fluorescence, not directly related to the oncology side of things in rectal cancer, but certainly in visualization, is that we can use dyes to identify the ureters. And we've seen some good work by the Oxford group with the recent paper by Barnes et al. About using methylene blue as a potential to identify ureters. Some of the work that we're doing at University College London as well is going to further look at this in human volunteers, and we'll be able to understand whether or not we can use different fluorophores other than ICG to identify conduits such as the ureter.